You're listening to Vet Synapse, a podcast connecting the world of research, innovation, and practical help to the veterinary profession. I'm your host, Dr. Philip Judge from Vet Education. Let's get connected with Vet Synapse. Hi everyone, it's Philip here from Vet Education. Welcome to today's podcast. What we're going to talk about today is a disease called acute liver failure. It also goes by a couple of other names, acute hepatic necrosis and acute liver necrosis. But basically, it's acute liver failure. What we're going to be doing today is having a look at two journal articles. One was a review of acute liver failure that was published in the Journal of Veterinary Emergency and Critical Care in 2015. And that was followed up a year later by a review of 49 cases of acute liver failure as well. And we're going to combine the data from these two papers, the review as well as the retrospective analysis of some acute liver failure cases, just to provide a little bit of a précis as to what causes this condition, what we can expect from our patients in terms of clinical signs, and what we need to do as far as treatment is concerned to ensure the best possible outcome. And from the outset, and one of the reasons why we're talking about this condition is that acute liver failure in dogs has a very poor prognosis. If you look at historical literature on this topic in dogs, mortality rates range anywhere from 80 to 90%. So let's get underway. So let's start off by defining what acute liver failure actually is. Among the many definitions that are circulating around in scientific literature, one definition kind of encompasses the majority of scientific thought on this particular disease process, and that is that acute liver failure is really defined as an acute decline in liver function due to injury or illness to the extent that it compromises normal liver functions. Now we know that the liver has numerous functions, among them protein synthesis, carbohydrate metabolism, gluconeogenesis, and glycolysis. We know it has a role in fat metabolism. We know it has a role in bile acid production, detoxification of compounds like ammonia through the urea cycle, for example. What else do we have? Bilirubin metabolism and coagulation factor production, as well as an important immune function. The Kupffer cells, a fixed macrophage system in the liver, is one of the largest immune organs in the body. So when we suffer from acute liver injury that's severe enough to compromise these functions, it's not surprising that we end up with a patient who is extremely unwell. At least in the human field, the definition of acute liver failure also entails that pre-existing liver disease is not present in the patient, that the patients who do develop acute liver injury or acute liver failure actually develop symptoms of hepatic encephalopathy, that bilirubin concentrations are elevated, and that there's also a presence of coagulopathy. Now, in terms of causes of acute liver injury, in the dog and also in the cat to a slightly lesser degree, there are a large number of hepatic toxins and diseases that can cause acute liver failure. Among the most common toxins that we associate with acute liver failure are things like sago palms or cycad toxicity, blue-green algae, amanita mushroom toxicity, aflatoxins, and xylitol. There are many drugs that are used in everyday veterinary medicine that can also cause acute liver failure as well, and among those would be non-steroidal anti-inflammatory drugs like carprofen and meloxicam. Acetaminophen or paracetamol toxicity is known to cause acute liver failure. Sulfonamide antibiotics, oral benzodiazepines in cats, and among other drugs as well might be included lomustine and stanozol and zonisamide. As far as infectious causes of acute liver failure are concerned, leptospirosis and canine adenovirus 1 would be the main or the most common infectious causes. In cats, idiopathic Hepatic lipidosis has been implicated or is known to cause acute liver necrosis and acute liver failure. And in a recent study looking at 49 dogs that were affected with acute liver failure, it was actually found round cell neoplasia and lymphoma are also likely causes in some dogs of acute liver failure. As far as the clinical signs of acute liver failure are concerned, they really reflect the role of the liver as a central metabolic organ. We can see symptoms of hypoglycemia reflected with central nervous system dysfunction, so dysphoria, depression, coma, or seizures. We can also see patients who become icteric as a result of hyperbilirubinemia. Patients can have occult bleeding as a result of severe coagulopathy, both as a result of the liver being unable to manufacture sufficient quantities of blood clotting factors, but also as a result of systemic inflammation and disseminated intravascular coagulopathy as well. In addition, we can also have severe sepsis as a result of the widespread inflammation and release of inflammatory mediators from the liver into systemic circulation. Now, the diagnosis of acute liver failure is usually made on the basis of routine blood analysis. Routine blood analysis typically reveals the presence of marked elevations in ALT and AST enzymes, to a slightly lesser degree alkaline phosphatase. We may see elevations in bilirubin concentrations. Blood ammonia concentrations may also be elevated. And finally, measurement of coagulation times frequently shows evidence of increase in APTT, prothrombin time, and activated clotting time. Oftentimes in combination with the presence of a severe thrombocytopenia if the coagulopathy is found in conjunction with disseminated intravascular coagulopathy. Many times when we're questioning owners about the patient's history, there may or may not be evidence of a clear, defined cause. Owners that have largely indoor dogs may well be able to exclude potential access to things like blue-green algae and mushrooms. But dogs that are left outside in the yard to roam by themselves, or that escape from the yard, or who are exercised off lead, can come across any number of hepatotoxins that may cause acute liver failure. It's important when we're questioning owners as well to review medication history, not only of that particular patient, but also other animals that are within the household. In addition, reviewing the medications that may be taken by members of the household that the dog is living in as well is equally important. Now, the treatment of the patient with acute liver necrosis really falls into three phases. The first is, if there's a known toxin, to decontaminate the patient of that toxin and to administer any antidotes if required or if available. The second phase of treatment revolves really around providing supportive care for the patient, things like intravenous fluids and so on. And the third phase of treatment involves managing complications associated with severe liver failure. And this is where we are dealing with hepatic encephalopathy and coagulopathies and so on. So let's just spend a little bit of time focusing on each of these three key areas. Let's first look at toxin decontamination and antidote administration to our patients. Most liver toxins don't have specific antidotes available, so that kind of makes things a little bit simpler for us. However, known ingestion or suspected ingestion of an enteric toxin should prompt us to evacuate the gastrointestinal tract using gastric lavage and enemas plus or minus activated charcoal, so that we can bind as much toxin as possible in the gastrointestinal tract and facilitate its removal to help reduce the quantity that's absorbed into systemic circulation. Drugs like paracetamol, for example, or acetaminophen can be managed as well with the use of N-acetylcysteine. N-acetylcysteine is a glutathione precursor. and is helpful in both dogs and cats as a replacement for naturally occurring glutathione, which can become depleted in states of toxicity. Mushroom toxicity can be treated with penicillin G at 300,000 to 1 million units per kilo per day given intravenously for the duration of that patient's illness. Likewise, the hepatic antioxidant silymarin can be given 30 to 40 milligrams per kilo per day per os for 3 to 4 days. In the cases of hepatic lipidosis that have caused acute liver failure in cats, the treatment for these patients typically involves nutritional support via placement of a feeding tube. In terms of supportive care, we're really looking at provision of intravenous fluid therapy to treat hypovolemia and to correct hydration deficits. When we're talking about intravenous fluid therapy, we're really talking for the most part about administering isotonic crystalloids. Ringer's acetate is actually preferred over lactated Ringer's solution in severe liver disease because the lactate in lactated Ringer's solution requires hepatic metabolism to convert it to its active buffer. Synthetic colloid fluid therapy like hydroxyethyl starch, for example, is relatively contraindicated in patients with severe systemic illness such as acute liver failure, and so we generally tend to avoid administration of synthetic colloids. Now, for patients that remain hypotensive despite adequate fluid therapy administration to treat them for hypovolemia, they may require the use of both positive inotropes and vasopressors to help maintain cardiac output and systolic arterial blood pressure, respectively. As far as positive inotropes are concerned, why are we going to use these? Well, several cytokines, including platelet activating factor and nitric oxide, are negative inotropes, and systolic dysfunction is strongly suspected in large numbers of patients with systemic hypotension and circulatory dysfunction secondary to severe sepsis or severe inflammation. So we use dobutamine typically in these patients with a dose rate of between 2 and 10 micrograms per kilo per minute. Among the vasopressors that we may use in order to help support systemic circulation, noradrenaline is the preferred vasopressor, and that's used at 0.1 to 0.2 micrograms per kilo per minute. For patients that fail to respond in terms of blood pressure to administration of positive inotropes to improve cardiac output and vasopressors such as noradrenaline in order to increase vascular tone, corticosteroids administered at physiological doses may be employed on the assumption that these patients may have critical illness-related corticosteroid insufficiency. And in some, perhaps not all patients, but some patients, you may see quite a dramatic response to administration of physiological doses of short-acting corticosteroids. We mentioned earlier that one of the key functions of the liver was in maintaining glucose homeostasis. It's quite common for patients with acute liver failure to develop severe and oftentimes sustained hypoglycemia. This can be amplified in some toxicities, particularly xylitol toxicity in dogs, where there may be an exaggerated insulin release from the pancreas secondary to exposure of the pancreas to xylitol. So we need to monitor for hypoglycemia, and if we detect it, to administer a bolus of no more concentrated than 10% glucose solution, usually at a rate of about 5 mL per kilo over about 10 minutes or so, in order to correct the acute episode of hypoglycemia, and then to place the patient on 5% glucose infusion at around 1 to 2 mL per kilo per hour to manage ongoing hypoglycemia. Electrolyte abnormalities such as hypokalemia, hyper or hyponatremia need to be managed as they arise in these patients. Very early on in the hospitalization of patients with acute liver failure, we need to be thinking about providing nutritional support. Enteral nutrition support is the preferred route of nutritional support, but it does entail placement of a feeding tube, be that a nasoesophageal feeding tube or an esophagostomy tube or a gastrostomy tube. Note that an esophagostomy tube and a gastrostomy tube will entail administering your patient a short anesthetic. So if your patient is not that stable, hemodynamically speaking, then you may be better off to start off with a nasoesophageal tube to begin with and start off with a liquid enteral nutrition diet. Now, aim is to try to feed up to resting energy requirements within the first 3 to 5 days of hospitalization. As far as the type of food that we should give our patients, at least 50% of the diet should be made up of either hydrolyzed or readily digestible nutrition for the patient, owing to the fact that activity of intestinal brush border enzymes, the ability of the liver to secrete bile acids that may help emulsify fats and so on, will be drastically reduced in these patients. In addition, vitamin K1 can be administered, as the ability of the liver to recycle vitamin K to vitamin K1 via the vitamin K epoxide reductase pathway will be reduced in severe liver injury. In addition, and this is particularly important in cats, thiamine should be supplemented on a daily basis at 5 to 10 milligrams per kilo every 12 hours or so. And lastly, as far as supportive care is concerned, the use of hepatic antioxidants is recommended. Among the most readily available hepatic antioxidants available are N-acetylcysteine, adenyl L-methionine, or silibinin, and they can be supplemented on a daily basis for the duration of the patient's illness. It's really unclear as to whether or not these compounds actually benefit and have a survival advantage in patients with acute liver injury, but it appears the risk to benefit ratio is reasonably low, and so we tend to give these patients these medications regardless because of the minimal risk associated with their use. Vitamin E is a free radical scavenger that may be considered as well to be administered. It's interesting that most studies carried out in animals in laboratories suggest that vitamin E may need to be given as long as 2 to 3 weeks before injury before it achieves significant antioxidant properties. So at this point, while it's recommended in some protocols, it's really, again, unclear as to whether or not vitamin E may be of any benefit to our patients in the acute illness. And the third part in our little triad of treatment options is to manage complications. Infection is an almost certainty in patients with acute liver failure, owing to the failure of the fixed macrophage system within the liver itself. In patients who are displaying signs of sepsis, either with an elevated or decreased white blood cell count, pyrexia, and alterations of heart rate and respiratory rate, plus or minus hyperlactatemia and other perfusion parameters, we recommend the use of antibiotics such as amoxicillin, for example, at 20 milligrams per kilo intravenously every 8 hours, plus or minus metronidazole at 10 milligrams per kilo intravenously every 12 hours. Coagulation abnormalities in patients with acute liver failure are extremely common. As we've mentioned before, the coagulation abnormalities really have two potential causes. One is disseminated intravascular coagulopathy that can result from the widespread release of inflammatory mediators into systemic circulation. And the second main reason for coagulopathy developing is the loss of hepatic synthesis of secondary clotting factors. Now, there is some controversy regarding the treatment of coagulopathy in dogs and certainly in people as well with acute liver injury. Currently, recommendations suggest that transfusion therapy with large quantities of fresh frozen plasma be withheld unless the patient is showing signs of acute hemorrhage or if they are about to undergo an invasive diagnostic or therapeutic procedure. Those sorts of procedures might include placement of an esophagostomy tube or a gastrostomy tube or obtaining a liver biopsy. Having said that, there are a large population of patients who will bleed continuously into their abdominal organs because they have prolonged clotting times. At the moment, it is unclear whether or not transfusions of fresh frozen plasma to patients who are not clinically bleeding is of any benefit. Retrospective studies in people suggests that fresh frozen plasma transfusion in patients who do not have occult hemorrhage is not associated with improved survival. And this is really the data that forms the basis behind our current recommendations. It's my opinion that further research in this field is required in order to establish whether or not we have a potential survival advantage in transfusing patients with acute liver failure earlier rather than later. We've mentioned another complication before, and that is hypoglycemia, so I'm not going to repeat that. The last thing I want to talk about with complications is hepatic encephalopathy. Hepatic encephalopathy in acute liver failure has a somewhat different pathophysiology to that hepatic encephalopathy that occurs, for example, in a chronic form of chronic disease such as portosystemic shunts. In portosystemic shunts, there may be a number of factors, including hyperammonemia, the presence of mercaptans, the ratio of branched chain amino acids to aromatic amino acids, and so on, that all may impact the development of central nervous system signs. But in acute liver failure, it appears the predominant cause for hepatic encephalopathy results from vasogenic edema secondary to widespread release of inflammatory cytokines. In terms of treatment, then, we're focused on something that's a little bit different than what we would in a chronic hepatic encephalopathy patient. To start with, we're going to need to make sure that a systolic arterial blood pressure is maintained between 100 and 120 millimeters of mercury. Hypotension is associated with worse neurological outcome, and hypertension, particularly in a coagulopathic patient, may predispose our patients to developing cerebral hemorrhage. So achieving normal systolic arterial blood pressure is essential in these patients. And we achieve that with the use of intravenous fluids, the use of positive inotropes, and the use of vasopressors at the lowest possible dose to achieve our desired outcome. We need to ensure that our patients with hepatic encephalopathy have adequate respiratory function. We can monitor arterial blood gas analysis, we can monitor pulse oximetry, we can monitor respiratory rate and effort. If any of these things falls outside accepted parameters, then intubation of our patient and ventilation for that patient may be recommended so that we can ensure that we have adequate gas exchange in the alveoli into the pulmonary capillaries to ensure we get adequate oxygen delivery to our cerebral tissues. In the euvolemic patient, that is the patient we've treated for shock, the patient that's currently on maybe inotropes and vasopressors, that suffers from deteriorating neurological function, we can then consider the administration of diuretics such as mannitol. Mannitol doses vary widely in the literature. Currently, doses between 0.25 grams per kilo and 0.5 grams per kilo given over about 10 to 20 minutes to patients is currently what is recommended. Convulsions in the patient with severe hepatic encephalopathy should be controlled with anti-epileptic medications, noting that nearly all of our anti-epileptic medications are extensively metabolized in the liver itself. Drugs like diazepam, midazolam, phenobarbital, for example. So in most cases, we're going to reach for short-acting anesthetic drugs, and propofol seems to be a reasonable choice in these situations. Propofol itself is administered at a rate of around about 6 milligrams per kilo per hour, adjusted up or down depending on the response of your patient. So that really wraps up the summary of what we're talking about when we are looking at patients or have a patient with acute liver necrosis. These are really challenging patients. They are expensive patients to treat. The mortality rate is reasonably high, but there can be some instances in which we achieve quite a good outcome for our patients. The prognosis overall does depend a little bit on the cause. In addition, there are a number of negative prognostic indicators that can help us when we're making decisions about treating patients with acute liver necrosis. For patients that have had cycad ingestion, marked elevations in ALT and bilirubin are associated with worse prognosis. And again, patients with low albumin concentration that have had cycad ingestion are also associated with a poorer prognosis. Patients with mushroom toxicity, blue-green algae ingestion, or the development of clinical bleeding or ascites during hospitalization also are associated with poorer prognosis and a negative outcome. So that's really what we had for you today in this quick review of acute liver necrosis. It's a very serious disease. It's a severe disease. It does require our prompt attention to try to determine the etiology of the acute liver failure, to determine whether or not things like gastrointestinal decontamination can be helpful. A large part of our treatment is involved in supportive care and in managing complications. And this really necessitates working very closely as a team with veterinarians, veterinary technicians, and veterinary nurses to closely observe these patients, to monitor them repeatedly for signs of deterioration, and to act early when signs of deterioration are noted so that our patients can potentially achieve a better outcome. Thank you so much for joining us today. I really hope that has been helpful, and we'll speak to you again soon. Thank you. Thank you for listening to this episode of Vet Synapse. If you like this episode, please subscribe to the podcast and share it with your friends and colleagues. Make sure to visit our website at veteducation.com.au for more great content and to experience the latest online race-approved veterinary continuing education.